Opioid crisis, a public health emergency. The objectives for this presentation will be to explore the origin of the opioid crisis, define the key terms related to the opioid crisis, state how the opioid crisis has affected the nation, describe existing laws and policies addressing the opioid crisis, identify the stakeholders of the opioid crisis, and compare the opioid crisis across the different states. And specifically, we'll be looking at the states Mississippi and Tennessee. Every 12 minutes in America, someone dies from an overdose. In 2012, healthcare providers wrote for 259 million prescriptions for pain relievers. In 2015, over 83,000 Americans died from an opioid overdose. In 2016, more than 2 million Americans had an addiction to prescription or illicit opioids. Dependence on opioids can happen just after 5 days of use, and 80% of heroin users started with a prescription painkiller. In 2015, the opioid epidemic cost the U.S. more than $500 billion. Please click on the link to the web page, The Crisis Next Door, which has a message from our president, as well as stories from different people that have had experience with the opioid epidemic.
For this presentation, we chose Nola Pender's health promotion model. This is a cognitive social learning theory. This model is useful in the control of unhealthy behaviors such as addiction. Behavior-specific cognitions to the theory include perceived barriers to action, such as poor support system, lack of financial resources, stress of life, the physical need for the drug, and side effects that occur when you do not have the drug. Perceived benefits to action would be a healthy body and general well-being, better relationships with family and friends, and a productive work life. Self-efficiency include engaging in healthy behaviors. Healthy behaviors might be rehabilitation facilities, support classes, attending AA meetings. Interpersonal and situational influences often affect decisions to make a change. One must make a commitment to form a plan of action for change. So what's included in a plan of action for a person addicted to opioids? What are we going to do to change this behavior? Detox to get clean and sober, possibly rehab for extensive inpatient therapy and counseling, social changes, changing the friends that are influencing us poorly, move to a better location where the drugs are no longer available as readily, engage in healthy relationships with new friends, family, partners, spouses, etc. Attend support groups such as AA, and then we have changes to a healthy behavior.
Before continuing with the presentation, let's define the key terms. Opioids are defined as a class of drugs that include the illegal heroin synthetic opioids, such as fentanyl, and pain relievers available legally by prescription, such as oxycodone, hydrocodone, codeine, morphine, and many others. Addiction is a primary chronic disease of brain, reward, motivation, memory, and related circuitry. It typically takes the brain 18 months to recover from addiction. And when you have opioid plus addiction, it yields for a long-lasting disease that can cause major health, social, and economic problems. These are just a few facts about the origins of opioids. Opioid use dates back to 6,000 years, beginning in Europe, China, and India. In 1803, opioid addiction became a public health problem. In 1827, morphine marketed by Merck for pain relief and alcohol treatment. In 1898, heroin was developed over the counter to treat colds, pneumonia, sore throat, and tuberculosis, and it was also thought to treat morphine addicts. Opioids was introduced in the U.S. between 1850 and 1870. Between 1900 and 1924, heroin was distributed in the United States over the counter to treat colds and flu. In 1916, oxycodone was introduced, and in 1939, meperidine was the first synthetic opioid created, followed by methadone in 1946. And in 1984, the U.S. adopted the Pain-Free Death Movement, which is known as the Compassionate Pain Relief Act. And in 1986, use of chronic opioid treatment for non-malignant pain was established. The key stakeholders that are helping to fight the war on opioids include the Substance Abuse and Mental Health Services Administration, which is an agency within the Department of Health and Human Services, the Drug Enforcement Administration, the Office of National Drug Control Policy, and many insurance companies. Recently, the Substance Abuse and Mental Health Services Administration announced that they will be accepting applications for $930 million in state opioid response grants. This money will be distributed to states and territories in support of their ongoing efforts to provide prevention, treatment, and recovery support services to individuals with opioid disorder. The Drug Enforcement Administration also has a portion of their administration where their function is to prevent, detect, and investigate the diversion of controlled pharmaceuticals and listed chemicals from legitimate sources while ensuring an adequate and uninterrupted supply of legitimate medical and commercial and scientific needs. Insurance companies are also starting to take a stance in the opioid crisis. Many insurance companies that provide coverage to their Medicaid and Medicare members are starting to monitor the amount of members that are on opioids, as well as members that are in substance abuse treatment centers and trying to seek for more assistance for those members. First attempts to regulate opiates in the U.S. was in 1875 by the city of San Francisco, who enacted the Opium Den Ordinance, which made it illegal to smoke opium in public. Then later in 1914, the federal government passed the Harrison Narcotic Act, which required anyone who imported, produced, sold, or dispensed narcotics to register and keep records of their operations. Later, the Harrison Act was replaced by the 1970 Controlled Substance Act and has been enforced since by the Drug Enforcement Administration.
Current regulations for prescription drug monitoring programs are being implemented in the states. State prescribing laws, as well as insurance companies requiring prior authorizations and limitations on the quantities of the opioids. And there is a lot of patient education on safe storage and disposal of the prescription drugs, such as opioids.
In this slide, it's just showing the opioid utilization by state. It is a state comparison of annual prescriptions per capita in 2015 of opioid products. And as you can see, Tennessee ranked number 2 and Mississippi ranked number 5. The following slides will discuss opioid statistics for Mississippi and the state of Tennessee.
In 2016, Mississippi had the 5th highest opioid prescription use in the nation. 348 deaths were related to drug overdoses, which is a 24.7% increase since 2011. 172 of those 348 deaths were related to opioid use. This slide shows the demographics related to deaths from 2011 through 2016. The highest race of deaths would be Caucasian at 649, and then males also had a high percentage of that total with 402 deaths that were male. This is the rate of prescription data for Mississippi for 2017, you can take a look at the numbers. First, second, and third quarter, there has been almost 100,000 rate of decrease in the number of prescriptions since the monitoring system started. In order to save lives from overdose, we want to reduce it. We're going to look for 3 signs in an unresponsive victim: pinpoint pupils, unconsciousness, respiratory depression. We're going to shake this patient, shout, and try to stimulate, and if we don't get a response, then we need to call 911 immediately. First responders often have naloxone available in their car, so if they find a victim and they've initiated help from EMS, then they're going to take the Narcan out of the package, gently place the plunger into the nostril, press it all the way down to release the naloxone, and then they'll remove it and place the patient in a recovery position until help gets there.
The number of overdose deaths in Tennessee from 2011 to 2014 has steadily increased. In 2014, at least 1,263 Tennesseans died from opioid overdose. For every one person who dies, there are 850 people in various stages of misuse, abuse, and treatment, according to the Centers for Disease and Control. That's at least 1,074,813 Tennesseans, or 1 in 6. More people died in 2014 from opioid overdose than in car accidents in Tennessee. More Tennessee overdose statistics. In 2016, there were 1,186 opioid deaths. In 2015, there were 13,084 non-fatal overdose outpatient visits, and there were 7,092 non-fatal inpatient overdose stays. In 2017 alone, 6,879,698 painkiller prescriptions were written. This is a diagram of Tennessee's most recent initiative to combat the opioid crisis. It is a part of the governor's Tennessee Together plan on ending the opioid crisis. It places more guidelines for and checkpoints between healthcare practitioners and patients before an individual is put on a chronic regimen of opioids. The National Safety Council recently published their 2018 Prescription Nation report on the opioid crisis, listing the key indicators that states need to put in action in order to fight the war against opioids. Those 6 key indicators are having mandatory prescriber education, implementing opioid prescribing guidelines, integrating prescription drug monitoring programs into clinical settings, improving data collection and sharing, treating opioid overdose, and increasing availability of opioid use disorder treatment. According to the report, by the end of 2017, only 3 states met all 6 indicators, and those 3 states were Nevada, New Mexico, and Rhode Island. 13 states are improving or at least meeting 5 indicators, while 30 states are lagging, meeting only 3 or 4 indicators, and 7 states are failing by meeting only 1 or 2 indicators as of December 31st, 2017. According to the National Safety Council's report, Mississippi and Tennessee were the 2 states that fell on the 30 states that were lagging in the 6 indicators. Mississippi met 3 indicators. Mississippi did increase mandatory prescriber education, they did increase treating opioid overdose, and they increased availability of opioid use disorder treatment. While Tennessee met 4 indicators, and those indicators were having mandatory prescriber education, implementing prescription guidelines, and also implementing prescription drug monitoring programs and treating opioid overdose. The next two slides will discuss House bills passed in Mississippi and in Tennessee to address the opioid epidemic.
Mississippi House Bill 692 allows practitioners to prescribe opioid antagonists to those at risk for overdose. This also provides immunity for a person who seeks treatment for an overdose. They won't get arrested if they seek treatment for an overdose. House Bill 996 allows pharmacy to dispense understanding orders from the state doctor, Narcan or naloxone. This also provides both criminal and civil immunities for those individuals who decide to administer naloxone and if they decide not to. For example, if they find an unresponsive person with alcohol bottles all around them, they may not think the patient had overdosed on opioids, so they can choose not to administer it.
Tennessee recently revised two House bills to address the opioid crisis. House Bill 1831 revises various provisions regarding the prescribing and dispensing of opioids and benzodiazepines and certain other controlled substances, while House Bill 1832 revises various provisions of law regarding the scheduling of controlled substances and their analogs and derivatives, including updated identifications of drugs categorized in Schedules 1 through 5, and authorizes sentence reduction credits for prisoners who successfully complete intensive substance use disorder treatment programs. Tennessee has established a plan to end opioid crisis called Tennessee Together. This is a comprehensive plan that involves the legislation, Governor Haslam's 2018-2019 budget of $30 million, and other executive actions to fight the opioid epidemic. The plan focuses on prevention, treatment, and law enforcement to help combat the opioid crisis in the state of Tennessee and ultimately the public health emergency that is affecting our nation. So in conclusion, we recommend that states continue to make efforts to meet the 6 indicators for combating the opioid epidemic. More specifically, Mississippi and Tennessee need policies and regulations that address data collecting and sharing of prescriptions, while Mississippi needs to implement prescription drug monitoring programs and implement prescription guidelines, and Tennessee needs to increase the availability of opioid use disorder treatment centers. So in order to fight this war on opioids, it is going to require continued collaboration with local and state leaders, the public, healthcare providers, insurance companies, pharmaceutical companies, and federal government agencies.